Today we will be reviewing a brief overview of signs and symptoms of those patients who present in cardiogenic shock, and then what do we do with that information once we discern whether or not someone's in cardiogenic shock or non-cardiogenic shock, like another form of shock. So with that being said, guys, I know it's been a while since I've made some videos, but thank you for being patient. Let's get into it. Notice today we are going to be going over some learning objectives. The big two ones I want you to focus on are just defining terms of what is cardiogenic shock and then understanding when you need to escalate that level of care. Notice I didn't say treat. We can treat it later down the line, but first I want you to be able to identify and recognize signs and symptoms and what that patient will look like in cardiogenic shock. That way, once you recognize it, you won't forget it, you won't miss it, and then you can escalate to those who have the capabilities at a larger center or closer nursing care and special type of medications that can be given in the ICU. So the question becomes, how do we define when someone's in shock? First, you're going to look at two parameters. First, the patient needs to have hypotension or low blood pressure and evidence of hypoperfusion. So hypotension we're going to define as a MAP of less than 65. They've probably been given fluids and there's still a MAP, mean arterial pressure, of less than 65. Now, when you look at hypoperfusion, I want you to think about two parameters. One is chemical markers and two, evidence of what we call end organ damage. So things to look out for: chemical markers. Here's the big organ systems: kidney, brain, heart, liver, and mesenteric organs. So the first one you're going to think about is the mesenteric organs, so the gut, and that would typically be found with a chemical marker of lactate. Someone's hyperperfusing if their lactate is elevated. In terms of kidneys, you want to look for chemical markers such as renal function, but you also want to pay close attention to the urine output. You'll say, like, the nurse will speak with you and like, oh, she's only put up 35 cc's in the last 24 hours. That's a bad sign. A lot of people miss urine output. That is a chemical marker. When we think of the brain, I want you to think more of end organ damage. So a lot of these patients that are hypoperfusing present with acute metabolic encephalopathy or confusion. They're altered. Maybe they're increasing somnolence. Those are signs that there's end organ damage, specifically with the brain. Chemical markers you can use for the heart would be troponins, proBNP, BNP, those type of parameters. And then liver, this one is often missed as well. You want to look for elevated liver enzymes. So that means looking at your AST, your ALT, sometimes your alk phos. And what you'll find is that patients in cardiogenic shock will often have what we call shock liver. So these are all different chemical markers and evidence of end organ damage to show whether or not somebody is hypoperfusing. So there's two branching points. One is cardiogenic shock and then non-cardiogenic shock. So every time you evaluate someone who you're like, oh gosh, this person is in shock, I want you to have pitchfork in your brain. You're either going to go left or right. Left, they're in cardiogenic shock, or right, they're in non-cardiogenic shock, which includes like obstructive, distributive, all those other septic, anaphylactic, PE, all those things are going to go into the non-cardiogenic shock side. So discern whether or not they're in cardiogenic shock or non-cardiogenic shock. So this patient, you can see there's some lab values here. Specifically pay close attention to the renal function. I didn't give you a baseline, so I'm sorry about that, but I suspect maybe the baseline's around 1. And then you'll see that these elevated liver enzymes are here. The BNP is remarkably elevated, and then you'll notice that lactic was elevated at 2.5. So this patient ended up having cardiogenic shock. Now that you have all these chemical markers and evidence of end organ damage, maybe that person previously was encephalopathic, maybe they were hypotensive, all these signs are pointing towards shock. And now you're trying to figure out cardiogenic or non-cardiogenic. So it always goes back to history and physical. You have to have a high suspicion that somebody's in cardiogenic shock. So anytime they have a history of heart failure, preserved ejection fraction reduced, mildly improved, any sort of ACS, arrhythmia, continuous resynchronization therapy, any sort of essentially cardiac history, that can actually predispose the patient to going into cardiogenic shock. Sometimes you'll see a pulse pressure variation or a wide pulse pressure. That's not always the case. If you do see that the patient's tachycardic, that's a good sign. That means their body's still trying to compensate. Remember, cardiac output is stroke volume times heart rate. So in that instance, when they're tachycardic, do not blunt the tachycardia. Let it go. Treat the underlying cause, but that's a compensatory mechanism for the patient that they're tachycardic. Now, one ominous sign you can see is when the person has cold extremities. They may or may not have crackles for you or lower extremity swelling. Just depends on like the wedge pressure and all that. And I'm not going to get into that, but the big one to look out for is cold extremities. That should be raising some red flags, and you need to think about cardiogenic shock. Now, if you're able to do a POCUS or an ultrasound at bedside, specifically for the cardiac windows, that would be super helpful. And then, of course, if you have cardiogenic shock, you need a right heart cath. Now, the treatment is going to be, now if they're in third-degree heart block, they need a transcutaneous pacing, or they need a higher level of care to get a pacemaker. If they're having a STEMI, NSTEMI, some sort of ACS, then obviously that's throwing them into cardiogenic shock. They need that treated immediately. And so I'm not going to go into too much of a treatment. I'm just showing you that these are the signs and symptoms you need to look out for. That way you can move into the next best step for the patient. I was initially going to pull a nice diagram from a nice like literature review and paper, but then I found this one with a bunch of smiley face, and I think this is probably easier to understand. Don't worry about the cardiac index. We can talk about that later. Don't worry about the x-axis with the pulmonary capillary wedge pressure. We can talk about that later too. The big picture, or the big takeaway I want you to look at for this Forrester classification system is there's going to be 4 quadrants here. You're going to see smiley face is happy, right? He's warm and dry. So these are probably people with like underlying heart failure who you discharge on guideline-directed medical therapy, and maybe they're back in the hospital, but they're warm and they're perfusing and their lungs are dry. So you still have a little bit of mortality increased risk with this, but that is, for the most part, a happy quadrant there, and you may not even need to do any treatment. Now, if you move over to your right side, and you see this little sad face with the raindrop on his head, that's warm and wet, and that's a Forrester class 2. So warm means they're perfusing well, but they have wet. So this group of people, they may benefit from diuresis, right? Pulling some of that volume off. Then we move kind of into that left lower quadrant there on the left side, and you see that he's got like a sweat bead on his head, and he's real sad. That's the cold and dry patients, and that's the Forrester class 3, and you'll notice their mortality increases up to almost 23% actually. And so they may have dry lungs, but these people are cold, so they may need some sort of ionotropic support. Okay, we won't definitively know until we like get in there and wedge and measure pressures, but that's kind of looking more shocky and looking a little bit more ominous. Now you move over to the far right quadrant, you're going to see him like very sad face, crying like, oh man, this is a cold and wet Forrester class 4 with a mortality as high as 51%. So these people are cold and wet. They need ionotropic support. They need diuresis. They may need some other advanced medications that the ICU can only give them. So this is a nice little disease state classification with the Forrester, and I like it because it's got smiley faces. So this is one way you can kind of group these type of patients in your head. And again, if the initial insult is a STEMI that's putting someone into cardiogenic shock, then you need to treat that, right? Or if they're going into third-degree AV block or some sort of arrhythmia causing the cardiogenic shock, you're going to treat that. But the question then becomes, how do we tailor our treatment, or how do we guide our treatment for patients who are in cardiogenic shock? Maybe they have a new reduced ejection fraction. You're trying to acutely stabilize them before cardiology can come see them, or before you can transfer them to a higher level of care. So there's a couple of things we can do. One, we can get a bedside POCUS, and if you guys want me to expand on what we find on that, I can totally dive into that and show you guys some pictures if that's something you're interested in. Another thing we can do is this FIC cardiac output. This is basically like what we call like a poor man's FIC. So this is a poor man's way of discerning whether or not somebody may be in cardiogenic shock. Now there's variables. It doesn't work as well if the person is also in hypovolemic shock, and sepsis may also sprinkle in some confusion with your readings if you pull it from a peripheral versus actually down in the uh, the SVC as opposed to like pulling it from the higher part of the central line. So there's variables that can affect the FIC, but if that's all you can do on the medicine floor before you can send them to ICU or at a smaller hospital where you don't have, critical access hospital, this may be something that you can tailor your treatment to while you're trying to acutely stabilize them. So what it is you just look at the oxygen consumption between the arterial and venous components, right? And then you're going to multiply that by just a regular old constant or a coefficient of 1.36. That's the oxygen carrying capacity of hemoglobin. And then you multiply the hemoglobin by 10. And that's going to give you your FIC cardiac output. If you need help, just look up at MD Calc, okay? So you can do your FIC, and you can also tailor your treatments, which is really fun to do with a right heart cath or a swan, and you'll do your thermodilutional components to that too. So the bottom two there are more advanced, and you need invasive monitoring for that. But the top two is something you can do to kind of acutely stabilize and escalate level of care. Obviously, you want to treat the underlying cause. So if there's a third-degree heart block or STEMI or anything like that, then you go ahead and treat that. But if you're stabilizing them and trying to advance them to a higher level of care or wait to see if they can get into cardiology and all these things, then we can tailor our treatment in the immediate future with these 4 things on the left side. So POCUS, we can talk about more of that if you guys want more videos on that. The FIC coefficient, which is like a poor man's way of discerning whether or not someone's in cardiogenic shock. If you pull from the periphery or the central line, it's not as accurate if you actually get it in the SVC, and that's fine. Some things that can falsely report your FIC coefficient would be like if somebody's also in concomitant hypovolemic shock, okay? So basically what you look at is you look at the oxygen consumption with the arterial and venous gases. So you pull blood from both the arterial and venous. You multiply it by that coefficient or that constant, which is 1.63. That's just what we use for oxygen carrying capacity. And then you're going to multiply that by the hemoglobin and times 10, and that's going to get your cardiac output. Just use the MD Calc, guys. It's in there for you. Now, next, you're also going to use a right heart cath, which is more invasive. You may have heard of it as pulmonary PA catheter, a right heart cath, a swan. That's how we invasively manage or monitor all of those values, and I'll go into more of that in a little bit. And then you do your thermodilution as well when you have the PA catheter in place. Here's a nice picture of the Swan-Ganz or a PA catheter. You can notice that once you're going in here, after you put the cordis in, and you're kind of following along these pressure gradients, and you're measuring each of the atria and then the ventricles, and then you're going to go into the pulmonary artery and then wedge it. And so you can get invasive real-time, second by second monitoring, and this is one way that you can tailor your treatments. I like this picture here. It's from a ECMO paper, and I can link it in the bottom if you guys want to read more about it. But basically, the way that they kind of have this little infograph is what you do to de-escalate and escalate on ECMO. But the principle, most of it, we extrapolate and pull for cardiogenic shock as well. So we'll do things like that echocardiogram, we'll do invasive cardiac monitoring, we'll look at the physical exams day to day and look at the peripheral perfusion and notice that maybe, oh no, they have cold extremities or they're molted. We'll get lab values every day, lactic and LFTs, kind of how we talked about earlier. ABGs and bicarbs are great. Not so much neurological status, that's more of an ECMO thing, but certainly if someone's encephalopathic, you may do an additional workup in the ICU. Of course, we're monitoring their respiratory status, and then renal function. So urine output, we're looking at their urine and sodium electrolytes, or excuse me, their serum electrolytes, and then looking at the urine. So I like this very comprehensive picture just to remind us of the things that we're doing kind of all at once to evaluate the patient who's in cardiogenic shock. Here's a nice little diagram here about the treatment based on your right heart cath or your PA catheter or wedge pressures. And you're going to compare that. Ideally, you'd like to do all three at the same time: thermodilution of the FIC and the pulmonary artery pressure, wedge pressures, and all that. That way you can tailor your treatment based on what your patient needs. So obviously, if the patient's hypotensive, you're going to be hypoperfusing and you're going to be reaching for something like a norepinephrine levophed. If you need inotropic support, you may use dobutamine, but it's pretty tachyarrhythmia. So maybe if you still need inotropic support, but you also need to improve the afterload, improving contractility, relaxation, inducing vasodilation, you may pull for something like a milrinone. But this is not by any means like this is exactly what you do in this type of patient type thing. You're going to be measuring invasively second by second, essentially, and titrating your treatment with these different medicines. So this is a nice little diagram to show you kind of vasoconstriction, dilation on the y-axis, and then ionotropy on the x-axis there. And then, of course, we have our classic milrinone versus dobutamine and cardiogenic shock, and the landmark randomized controlled trial. It was double-blind, performed or published, in the New England Journal of Medicine. I'll link this study down below as well. Essentially found no difference between both those groups. And in both primary, secondary outcomes, mortality, length of stay, all that stuff, it was the same. And so you this kind of goes back to the age-old adage of just treat the patient in front of you, and everyone's different in their own way. And so we need to tailor our treatment to that specific patient. You can't group them all in the same group. So that's that landmark trial. I'll link it down below for your help too. And if you guys have any questions, if you want more videos like this, let me know. If you want an ultrasound video, I can try and pull something together for that. In the meantime, happy studying. And if you guys have any questions, I'm here. I'm sorry I've been away for a little bit, but I'm back at it and I'm happy to be here. And thank you so much for your time.